All right. Just a few things to start with. Follow principles of pain management. Remember that. Patient right patient. The patient's always right. Subjective, objective signs, not always sensitive. It can be in pain members an unpleasant sensory and emotional response. Can exist without an identified cause. It's psychological, affective, cognitive, behavioral, and sociocultural. Every patient, remember, deserves adequate pain management and base treatment on the patient's goals. So what is a tolerable amount of pain for you? Use drug and non-drug therapies. It can be multimodal, more than one drug class. Multidisciplinary approach. Evaluate the effectiveness of all interventions and prevent or manage the side effects. And incorporate patient teaching into what you're doing. All right. Patient profile. So you can see your 4 patients that you're caring for today are going to be Missy Muffet, Jack Horner, Mary Contrary, and Georgie Porgy. Okay? So let's first look at that page. So as you can see here, and you can write your report then beside these people. Missy Muffet's 83, diagnosis osteoporosis, compression fracture. Activity, ambulate, QID with assistance, general diet, vital signs every shift. She's got a saline lock in place. She's got OT and PT therapy. She's on Fosamax weekly. She took that last Monday, vitamin D, calcium, ibuprofen, and she gets Dilaudid, 1 milligram IV every 2 hours. And she taken at 1:30, 7 a.m. and 11 o'clock. Jack Horner, you can see down here, he's got DJD. He's still in PACU, though, has a right hip arthroplasty. Activity out of bed with PT in the AM. No added salt diet. Vital signs every 30 minutes. You can see his vital signs. Pulse ox, if less than 90%, start O2 at 3 liters nasal cannula. His IV fluids are going to be D5 normal saline with 30 milliequivalents potassium per liter at 125 per hour. If he's taking oral fluids, well, we can saline lock him. SCDs while in bed. He needs an abduction pillow. Keep heels off bed. PT and CBC in the AM. Assesses dressing with vital signs. Medications, you can see cefazolin, which is what is cefazolin? So antibiotic, exactly. Warfarin, enoxaparin. Why is he on both Coumadin and enoxaparin at the same time? All right. So what we're going to do is prevent those blood clots from forming now, and we're going to get him started on something because Coumadin doesn't work right away, so we're going to bridge that gap there. Get some Zofran, naloxone, morphine, and epidural for pain. You can see Mary Contrary there. She had a total abdominal hysterectomy done yesterday. She's ambulating, full liquids, advanced to surgical soft. Vital signs with pulse ox every 4 hours. Her IV is normal saline at 75. You want to check her perineal pad every 4 hours. Change her abdominal dressing daily in PRN. Foley to gravity, discontinue at 2400 today. Medications, she's on Cefitin, or 1 gram every 12 hours. She's on Vicodin, and she's getting morphine every hour PRN. Georgie Porgy, on the other hand, has sickle cell crisis, and we'll learn about that in our hematology unit. He's on bed rest, diets as tolerated, vitals and neuros every 2 hours. His diet, you can see, encourage fluid intake to at least 3,000 mils per day. He's got IV fluids running at 150 an hour. He gets Colace, Ambien to help him sleep, Phenergan for nausea and vomiting, hydroxyurea, Dilaudid, and ibuprofen as needed. So there's your 4 patients today. Now we're going to get a little bit of a report here. In 401 is Missy Muffet. She's 83 with osteoporosis and compression fracture. You can see we're encouraging weight-bearing activities, and she has been out of bed twice on our shift. She walked the length of the hall. Her pain did increase to an 8 when she is active. She's working with PT and OT, but she may need to go to a nursing home for future therapy because before she's able to go home. She does live alone. Her last dose of Dilaudid was at 11 o'clock. This lowered her pain to a 3. Now, in 402 Jack Horner, he's 61, having his right total hip today. He's still in PACU and will not be in the unit for another hour. We do have a copy of his post-op orders we talked about, and they look pretty routine. Mary Contrary, though, is 44, had her TAAH yesterday. She's ambulated on our shift twice and doing well with activity. She's tolerating full liquids and states she's ready for some solid food. She has already needed her peri-pad changed about every 3 to 4 hours. Her abdominal dressing has a small amount of old, dried serosanguinous drainage. She does get good relief from her Vicodin, but the pain seems to return quickly. So she had 2 tabs at 0030, 0430, 09, and 1300. Excuse me. Now, Georgie Porgy, should remember him from his previous admissions. He's 22 and here with a sickle cell crisis, complaining about pain at an 8 and joint pain at a 10. The Dilaudid lowered the pain to a 5 or 6. His last dose of Dilaudid was about a half hour ago. I've not seen him since that time. He's on a 6/12/18/24 schedule for ibuprofen. And he had 1 dose of Phenergan at 10:15. He's had no nausea since that time. He's taking fluids well. He tries to take a glass of water juice at least every 2 hours, and his O2 sats are 98 to 100%. Okay, so that's your report there. What? I know, but that's the way they go, isn't it? Okay, you just received a report from the day shift nurse. What are you going to do now? Give report to the CNA, review today's lab results, review the patient's MARS, start assessing my patients, or do you want to do something else? Well, honestly, you can decide you can do whatever you can start your day in many different ways if you so choose to do that. But what do you think is going to be most beneficial here? Getting my cup of coffee first is more important, okay? So now, considering we have the cup of coffee, you're going to want to do a couple things. You're going to want to review the patient's MAR, right, and look at their lab results. And then you're going to want to talk to your CNA and then give report. I don't care if you look at the lab results and then the MAR, but in some order is similar to how you're going to want to do that. Which patient are you going to see first here? Missy Muffet with a compression fracture, or Jack Horner with a hip replacement, Mary Contrary, or Georgie Porgy? Okay, Jack's not there. I agree with that. We're not good. So Jack, we're not worried about Jack right now, are we? Mary's okay.
Georgie's pain is still up there.
Okay. Georgie's pain is still up there. I must have a different. Let me see if I can find this. So what are you thinking then? Okay. Now let me ask you this question: who received the IV pain medication and was not assessed when we gave report? Do you remember? Did you write that down? Okay. So remember this one, the Dilaudid. So who got the pain medication? Georgie. So his pain was a half an hour ago. When do you want to recess his pain?
Now.
Right. So who are you going to see first? Georgie Porgy. Exactly. So Georgie Porgy is laughing and visiting with friends when you enter the room. When you ask his level of pain, he states his last Dilaudid did not help, and his pain is still a 9. So what are you thinking? So A, would you be thinking A? No. Okay. How about B? How about C? No. How about D?
Possibly.
You could be thinking something else, exactly. But remember, just because he's laughing with his friends when you enter the room, and he says his pain is a 9, he can have his Dilaudid how often?
Every 4 hours.
Oh, okay, so he is not due for his Dilaudid, is he?
It says as soon as it is.
Exactly.
It doesn't say that
Right, so
now.
we could give it to him as soon as it is due. But then I did hear you could also think of something else with that, correct? You could, and what are you thinking? Which,
Other than physical pain.
so what are you thinking?
Well, yeah, I'm open. But when maybe not that one. But if it's a 9, I probably would be complaining.
Okay. okay? So we could think of definitely, we could think of something else here in this case, because he may need a little bit something more for that. So we may want to call the MD and get something else for him. Good. Mary Contrary puts on her light at 1800 and requests a dose of Vicodin. She states her pain is a 5. What do you do? Well, let's think about when did she get her Vicodin? And so what time is it? So what are you going to do? Absolutely, let's do B. Let's give her 2 tabs of Vicodin. It's time for a Vicodin. This I just added in here just to know about liver failure and a warning and how this impacts your role as a nurse, just to make sure that we are doing good education to these patients as to why they are on Tylenol. All right, Jack Horner. He's returned now from PACU. His dressing is dry and intact. He has 300 mils of drainage in his hemovac. His SCDs and abduction pillow are in place. His vital signs are comparable to those in PACU. Assuming the following have not been done, what would you want to assess next? What do you think? See his level of consciousness? What did we talk about with PCAs? Which way does the pain medication go? Down, exactly. Yep, so it goes caudally. Okay? So he's just come back from the PACU. What do you want to check first? What do you, huh? Absolutely. Yep, so let's take a look at his epidural and make sure that the settings are appropriate for what they are. Okay? And then we're going to look at his epidural insertion site as all part of it. And then, do you think he should have numbness and tingling in his extremities? What do people complain about when they have an epidural in? Huh? Right, you can't feel nothing. Kind of feels like they're numb. So, but they may they may complain of that numbness in lower extremities. That would be normal. What about his level of consciousness? Is that something you'd want to check right away? No, because that pain medication goes caudally, so it should not affect it. So if this guy's level of consciousness is off, should be thinking something else is going on with that. So good.
I don't understand that, because when our patients came back last,
That would be the effects of anesthesia.
okay,
Anesthesia effects is what you're thinking of. It would not be the effects because your epidural goes caudally. It does not go to the brain. All right, the CNA ambulates Missy Muffin and his sister to the bathroom. Which of the following reports by the CNA requires your most immediate follow-up? A, what is that telling you? She's got a possible GI bleed, exactly, so that's going to be our concern there. That's going to require us. She doesn't state she wants to walk anymore today. Well, I don't know how many, I can forget how many times she's ambulated, but that's not our immediate follow-up. She's worried she'll become addicted to pain pills. That's not our immediate follow-up. And respiratory rate, well, if it increased, exactly. So our biggest concern here is those black stools and possibility of GI bleed. I will not test you on this type of thing on the test, but I just included it. Jack Horner's enoxaparin is ordered as 1 milligram per kilogram. It's available in 100 milligrams per 1 ml. How many milliliters will you administer? He weighs 176 pounds. What do you have to do first? Yeah, you do. Okay. So roughly, because we can't give 0.76, can we? Yep, good. The physician decides to change Georgie Porgy's medication from every 4 hours hydromorphone to morphine PCA pump. The following are true and false questions. It can be anticipated that morphine dose in milligrams for a 4-hour period will be lower than hydromorphone dose in milligrams for a 4-hour period based on the equal analgesic chart. What do you think?
morphine dose would be lower than the hydromorphone dose. Or the same effect.
Okay.
Morphine is more effective than hydromorphone.
And the correct answer is false. Hydromorphone, oh, where'd I go? I gotta come this up here. I don't want you guys to see all these answers. False. Hydromorphone is a powerful medication, and is ordered in smaller amounts of morphine. So 1.5 milligrams of hydromorphone is equivalent to about 10 milligrams of morphine. Now, the nurse should push a PCA button each hour during the night to prevent pain development while Georgie is sleeping. Why not? Why can't I?
Patient control.
Yeah. The patient is responsible for pushing the button. If medication is needed during the night, the physician should order a continuous delivery. In many settings, a policy will prohibit the nurse from delivering a dose until a specific order is written with that, giving the permission to do so. 2 registered nurses verify the PCA pump setting when it's set up. Absolutely, we should always be doing that. That is because it's considered high risk. Good. All right, talking about equal analgesic, this is what we're looking at here. Remember to understanding and remember the chart is useful when switching from oral, from parental to oral routes or oral to parental. So this is just, I've just include this in here. Yep, that's the same thing as what's in. Yeah. This will be available in Blackboard. True or false? Routine patient assessment following initiating PCA therapy includes pupil size and reaction, blood pressure, pulse, respiration, sedation level, pulse oximetry, and effectiveness of analgesia. Really? You think so? I disagree. Pupil size and reaction are not a routine assessment for somebody on a PCA pump. So, it's not going to hurt you to check it, but you're just making extra work for yourself. So the patient would wonder why you're the only person that's doing this. O2 sets automatically are done with a pain assessment, and sometimes a person will have O2 set monitoring, but sedation level is important too with that. The nurse should anticipate that the loading dose and the demand dose will be the same amount. No, of course not. Of course not. No. The loading dose and demand dose may be the same, but they don't have to be the same. They do not have to be the same. The loading dose is the first dose they receive, remember? And do you know why we give them that first dose? Blood levels, exactly. Get that blood level up of pain medication. And then the demand dose is what they receive when they push the button. The settings on the PCA pump should be checked at the beginning of each shift. Yep, and don't assume that the pump is set up correctly. I found many errors. I've actually seen patients where they've had an epidural infusion running through their IV, and the IV one was running in somebody else's through their epidural site. Yeah, not good. If a patient complains of pain greater than a 5 while on a PCA pump, what should you do first? Oh. What's the first thing you want to do?
D or D?
Well, which one? The nursing process said you should do,
Check if they're using it as ordered and then check.
If they're getting it, I would say, yeah, you could do it.
you're going to need more information before you call the doctor. So determine if the patient's actually trying to use a PCA is a good place to start. Are they actually pushing the button? So the correct answer is yes. If they're pushing the button, is the machine delivering the dose to their vein? Just because their pain is unrelieved, I would not assume that they do not understand the pain scale. I've actually seen where patients complained of pain. Nurse didn't trace the lines, and the patient's infusion was on the floor. Yeah, I wouldn't want to be that patient, would you? It's 8 p.m. and Missy Muffet is requesting a dose of Dilaudid. What do you do? Yep. Yep.
A and then find some other way to help her relieve
She
the
has
pain.
it at 1,800, she can have it every 2 hours.
Her last dose was, when was her last dose? Didn't she get one at 11 o'clock
We gave her one at 1,800.
and 1,500? Oh, okay.
Remember, she asked.
And giving her a dose, well, and if she can have it how often?
Every 2 hours, so she can have it.
Absolutely, there you go. And giving her a dose immediately fits the orders. You could do something else, because you'd likely want to assess further before treating the pain, but she can have her Dilaudid if she chooses. Mary Contrary will be discharged on Vicodin. What do you need to keep in mind as you prepare discharge teaching for Mary? Yeah, A. So you know what? She needs to avoid constipation, so we want to talk to her about consuming adequate fluid and fiber. Jack Horner experiences numerous side effects from his epidural PCA. Which problem takes priority? Yeah, so numerous side effects from his epidural PCA. Respiratory rate is 8 breaths per minute is the one that you should be looking at. But while you should be concerned about any of these findings, the respiratory rate is most concerning there because we need to figure out why he's breathing so low. I did just include the WHO here. You can see this for mild, moderate, and severe, what you can give these patients. Patient rates pain as a 6. What are some other options you can give them?
Any options besides the severe medication?
Yeah. Well, if pain is 6, what can we give him based on the what are you going to give him? Yeah, so what you're going to do is look at things that are within the moderate category. If he rates his pain as an 8, what are you going to do? We're going to look at giving him severe, exactly. And then what about if he rates his pain as a 3? Exactly. Oh, I should have done that, sorry. Yep, exactly. Pain terminology here, you know, when we think about the different types of pain, you know, we have acute, chronic, cutaneous, neuropathic, referred, somatic, and visceral. We did talk about these in class, and so you could see that by doing that. Ethical terms, just a little bit of review on ethical terms. We talked about these. Again, same thing as what you saw before. Which medication is the best choice to treat breakthrough pain for a patient who is receiving methadone 10 milligrams every 8 hours? Well, you know, methadone is a very, very strong opioid. So if you gave something in addition to methadone for breakthrough pain, you should give them something strong. And so you would think about giving them something that works right now. So you're thinking that you would give him immediate release morphine. For patients who are receiving opioids for analgesia, tolerance exists when? What is A? Addiction. What is B? Addiction. What is C? Yep, chemical dependence. What is D? And E is? Exactly, good. Who will you treat with Narcan or naloxone?
So he's having overdose or respiratory.
Yep, somebody who is overdosed or if you're concerned with respiratory rate. Or pruritus, exactly. How would you make a patient referral? You know, for like a visiting nurse association. And this is just something that's included here. You're going to want to know when you're filling this out, and this is just some of this is just FYI, you know, what to include. You know, if you're going to make a referral for somebody, overall physical condition, general level of sedation, weakness, fatigue, constipation, nutritional problems, sleep patterns, functional status, and that SBAR that we talked about earlier. You know, the situation, background, assessment, and recommendation. Referrals, You can see here, PT, nurse specialist, hospice, home infusion, healthcare, and pain clinic. Part of your ticket in this week was to look at those types of patients. A patient with phantom pain is likely to be treated with which one? So what is phantom pain first off? Amputation is what you think of. So I've had an above the knee amputation, and I tell you that my toes are really, really sore on that foot. That's phantom pain. There you go. A is the correct unit. A is the correct answer. TENS is going to be for neuropathic pain, so we wouldn't use that. Continue sub-Q infusion through a small 25 or 27 gauge butterfly needle into the subclavicular or abdominal subcutaneous tissue is done with a CAD pump, exactly. True or false? Oh, let's see. Alternative methods of pain relief are intended as substitutes for medication. They're used in addition to medications. Effective pain management helps lower healthcare costs. Yeah, there's many negative effects of untreated pain. Older people don't feel pain as intensely as other adults. What happens there? They tend to complain less, exactly. But that doesn't mean they don't feel pain as intensely. Opioid addiction among people being treated for pain is very rare. It is rare, less than 1%. Time spent educating patients about pain management takes away from meeting pain management goals. Providing patients with education about pain is part of pain management and will help meet pain management goals. Meningitis is a possible side effect with? Yep, B. Meningitis. Epidural catheter. An epidural's local anesthetic effects, which are dose-dependent, occur progressively. A patient will lose sensitivity to pain first, then to, we didn't really talk about this. Pain first, then what? Yeah, temperature and touch. Then the rest will follow after that. True or false? Let's see. Patients' cultural and social backgrounds may influence how they report or describe pain. Exactly. It's easier to prevent pain than it is to control it once it starts. Oh, I guess so. Fentanyl is an example of an adjuvant pain medication. It's a opioid, exactly. Under Joint Commission standards, information on pain management is not part of patient discharge plans. False. Joint Commission requires it. Which is an example of titrating pain medications? Exactly, you should have chose B. Titrating involves determining the optimal dose while avoiding side effects. It typically involves making increases and decreases to the dose. My battery's going to run out. True or false? Patients tend to ask for more medication than they actually need. No. Pain is often undertreated. The most reliable source of pain information is the patient. It's not safe to keep giving pain medications for a long time. False. You're right. It has to do with chronic pain, so that is false. Physical dependence on a drug is the same thing as addiction. They're interchangeable. No, you're right. Many patients are unwilling to admit they're in pain. Yeah, there's